the recording, but if anybody can access that,
oh, somebody's done that. That's wonderful.
Be really grateful. Bless you. Thank you. Thank you, Mr. Holding. Top man of the years. Brilliant. That's 12:32, Jyoti. Yeah, time check. Brilliant. Thank you. Thanks to everyone. I'm just checking in. Can people see the screen with the hospital only discharge collaborative approach sign? Hi, my name is Rob Kemp, and I'm just going to be curating things this afternoon just to make sure that we start on time and we finish on time. I suspect all of the content will come from our lovely clinical associates and other colleagues on the call. As part of the hospital only discharge collaborative approach, we were asked to support this way back in the tail end of the spring, and we're working across 15 sites. Excuse me. That's better. And as a result, there's a number of learning events. Now I'll take you through a little bit of the history of the programme, and we'll do some introductions as we go, if that's okay. But while we're doing this, if people have joined from far-flung places, please drop who you are and where you're from in the chat box, just so we can see the scope of the people arriving. So in terms of why we're all here today, and that's not a philosophical question, it's more to do with the discharge, hospital-only discharge approach. As you can see, 15 organisations that we're supporting, and the key aspect for us is that it's a reflection of the sites that are taking part. So collaborative in the truest sense of the word, where we're taking the expertise of the individuals, reflecting that back and sharing it across the systems, as opposed to some descriptor from far afield. And thanks for those that are joining, and I really would really appreciate the fact that people are giving up time in their extraordinary busy weeks to attend this. So we'll try and make it as succinct and supportive as possible. Thank you. Right, okay. 4 key areas of our approach was obviously the frailty and deconditioning stuff that we're going to be talking about today, the workforce supporting operational process, and ward and board rounds, and we'll get into some of the detail of frailty and deconditioning today. We are providing specific support for those 15 sites, but additionally, the learning events are open to all. So this means that we can spread our net a little bit wider, get some expertise from further afield, and bring that to bear on those 15 sites that are in the midst of the hospital-only discharge work. So in terms of the background, 4 events per each one of those 4 themes. They are clinically led. We've imported keynote clinical colleagues from across the country to help us with this. And this is about sharing top tips and developing our approaches. And at the end, there'll be a facilitated question and answer. But please keep it interactive over the course of the session today. Put your questions in the chat box, and we'll endeavour to come back to those a little bit later on. Sometimes, I don't know about you, but I lose my train of thought and I'll forget about the question. I'll think, oh, I've got a good question, and I'll forget about it when it comes to the end. But it'd be really great if we can capture some of those as we go along. And because it's recorded, the resource is open and shareable with all. Right. Let's move on to the next slide. This is a reiteration of the other slides, but in a way that demonstrates that these things are connected to improving flow. And if you're going to take a group of the key ingredients, you would look at the consistency and the reliability of the way we work within discharge processes. So this will be a recurring theme that we keep on coming back to as we refer to flow. Right. I'm getting a bit of noise. Oh. Okay, cool. Thank you, whoever that was. So the workstream objectives, way back to the earlier sessions: optimize patient pathways and balance risk, implement sustainable changes using a quality improvement approach. And it is easy to recognise we do something and then it doesn't have the legs, if you like, to carry on through. And this is your chance as well to showcase some of the good practice that not only we developed internally, but your practice through the collaborative, and we'll bring that to bear a little bit later on in the session. And there we go, a wise old word or two there. Right, if we remember back to May when we did the launch event, we asked you what are you most proud of, what you see are the current barriers to discharge, and what support might be useful. So we did a Menti session then, and we put all of that together. And the next slide is a little bit busy, but it gives you some of the themes that Bharath will attempt to cover off in some of his session today. And so some of the themes around what you're proud of. There's a lot of teams recognizing they've got a Frailty front door team. There's usually a high user or high intensity user group within systems. There's a recognition that staff commitment's really high to develop Frailty services across the board. And some of the work that you've already done in scaling up your Frailty approaches, how you link the health and aging strategy and you connect with your councils, and how you score for patient Frailty. Also, as he moves his screen, there's rapid access clinics for admission avoidance, and a lot of these things in isolation you're proud of. But one of the things that Bharath will talk about today is not only some of these things themselves, but how they perhaps are joined up together. Some of the barriers you described, and there's a lot of repetition in here. Workforce availability, organisational culture. Some of the words reflected organisational and perhaps even system culture. Resilience 24/7. It's frailties 24/7, not just for those select times of the day. And then how do we work around those evident gaps in our workforce right now? And your suggestions, and some of these were suggestions about what sort of support you might require from the collaborative, would be how to develop that sustainable offer. How do we stitch these things together? How do you shift culture so there's a sense of engagement right across sites and systems within Frailty? How do you improve efficiency? And some of that, it goes back to the process stuff. How do you reduce delays, streamline care? How to work across those traditional boundaries that we have in systems, and I think that relates quite well with improved seamlessness. And I suppose that's you ask any system how integrated they are, you may get one answer. Ask a patient how integrated it felt, and you may indeed get a slightly different answer. And beds put in ambulatory areas, and I suspect that was one of the barriers, and so apologies for that. So there's a lot of ground to cover today, and I don't want to put too much pressure on our key speaker for today, but it's Bharath, and I'll let you introduce yourself in terms of who you are and where you're from, Bharath, and if you just give me a nod in terms of pushing on the slides for you, sir. Is that okay?
That's perfect. Thanks, Rob. I like that picture because I don't look like that anymore. Must have been a few years ago. So greatly appreciate that one, Rob.
Thank you.
I'm Dr. Bharath Lakatwa. I'm a consultant geriatrician and also the clinical director in Northamptonshire Healthcare Services for adult services in the community. And I've been a clinical associate for a few years now. Jyoti Nipani, who's my clinical director as well, he recruited me, so I've been in this. My main focus is community geriatrics. I've been doing it since the year 2000. And my focus is functional pathways and integration of frailty care along the system. So I've been doing this for a while now. So hopefully, if I'm saying something today, it's mainly through experience. And if you go with the flow, I'll take you through the program. So thank everybody for giving me this time. Just 1 second. I'll just wait for that one. If we could go back, I gotta explain what's happening in my brain before. I think the quote which Rob put up, Einstein, I'm very familiar with it. It's been a while as well, so it reminded me of my granddad. Yeah, I think he used to clip me behind the ears when I was 12 or 3, and it's the exam quote, same quote he used. I never thought this quote's going to come back later on in my life as well. So the other thing is, developed this model only in the context for myself because one thing which is a constant in the NHS is change. So I needed to adapt myself to whatever change comes across. And then any new guidance, any new kind of changes, any quality standards, it needed to fit into that. I have a simple brain, so I specialized in geriatrics so that everything which is complex, any complex task becomes a functional task. So I had to do this mainly for myself, and then following that one, I had to use a few principles, the principles which we are all aware of, the right care at the right time in the right place. So that is what it's based on. But like anything else in life, if you don't know what you're looking for, if you don't identify what you're looking for, it's kind of hard for us to know what to do. Without identification of frailty, how are we going to get any help for these patients, and how are we going to help yourself? Then, and if they are being identified as frail, what do we do next? They need to progress. That means you need to treat them, you need to do something else for them. And following that one, we know there's data as well available, which says, if you look at most data, we had local data here, we've done it a few places, around about 50% of the frail patients, when they get admitted to A&E, from A&E into the hospital, nearly 60% don't even have IV antibiotics or IV fluids. They're still admitted. That means this can be done at home as well. So we need to do some kind of monitoring for them if they're going home. The bit which is, again, important is that if they are monitored, then they need to be going home. So how do you maintain them at home is by being independent. I think we need to keep in mind a few things over here. The highest growth in the frail population is 85 plus. If you think of it as numbers, these were the 1940s and 1950s. They've been through the Second World War. These are seniors and elders who have been through a lot. They have been in control of their lives, and they want to take control. And you see that day to day on the wards as well. The bit which really was amazing for me was when you asked them what works for them, they were able to tell me what works for them. And they were thankful for listening as well. So one of the lessons of COVID is in the beginning 3 months when we started having the PCR tests, we did have a 103-year-old gentleman who was positive for COVID at home with a rapid response. And as usual, everybody in the rapid response team, myself, including the rehab technicians or pharmacist, has to do news to observations on these patients. And we get a phone call from one of the rehab technicians saying this gentleman's sitting saturation is 67%. He's talking to me, he's eating and drinking, when he doesn't want to mobilize because he feels tired. So they shifted him to the bed. And 67% as a medic or any medic, you're going to jump out of your chair and say, this patient needs to go in. So he was very frank to us. He said, I'm 103. I don't want to go into hospital. I've seen the news in Italy. I don't want to be part of that. And what we learned from him is he actually said the next sentence, I will die. I'm supposed to die. I'm 103. What are you going to do about it? So we didn't know what to do. So we did a DNA CPR, we did a sealing of care. Our GPs were lucky that they were part of the treatment plans over there. So, and he actually survived. So what it taught us was just listen to the patient. Sometimes they are telling us what's right. The reason I keep this in mind was because this was an extremely frail gentleman who was living independently with his children in the 80s. So who do you listen to, the children in the 80s or the gentleman who's 103? So he survived. Unluckily for us, 8 months down the line, he had a fall, and then he was no more. So he used to write to us regularly as well. With identification, next slide, please. Identification is, if you know what frailty is and what you need to look out for, then in the simplest terms, it's the characteristics of frailty you're looking out for. Most of the time, it's from the history. So there's an interesting study which came out when they looked at the amount of history taken from an ambulance paramedic to the one coming onto the ward. There were 6 histories taken, and out of them, the best history taken was the paramedic in the ambulance. The history got completely cut down, nearly to 70% of the history taken by an ambulance by the time the patient was admitted to ward. Again, as we know, how do we exactly find out about frailty is asking the patient. What do they do during their day after they wake up? It seems to be a simple question which tells you most of the characteristics of frailty. I put this slide up because this characteristics of frailty, if you got 3 of the following findings or 1 or 2, it's pre-fail. That's a research published study, but how do you put it into practice? I mean, let's go backwards. So usually when you get the history, you check for low activity. The low activity is because they are really, there is due to the slowness in them. And then if they do more, they get exhausted, and that leads, and also because of poor endurance. And then it's a vicious circle. The less that they do, the weaker they get. And don't forget the omnipresent sarcopenia, which starts at age 27. I only found out when I was doing my fellowship 25 years ago that I was too late for sarcopenia. I'm of Asian Indian, South Indian descent. So my sarcopenia started at 24.5 years of age. So there was no hope for us then. So I think sarcopenia is omnipresent. So looking at characteristics, then again, if you look at the physiology of aging, patients don't feel thirst. There's poor thermoregulation. They don't sweat. There's lots of things to add into this one. Again, a patient coming into A&E who's frail based on the characteristics, low activity, slowness, weakness, and then exhaustion. When they come into hospital, we know the data is very clear. 93 to 95% of the time a patient spends their time in hospital, which is horizontal or sitting in the chair. That leads to deconditioning. I won't talk about deconditioning because we got the oracle of deconditioning, Dr. Amit Arora, who's going to be leading one of the sessions, and that'll be when we cover a little bit more about deconditioning. Next slide, please, Rob. So again, there's lots of scales. We are a clinical workforce who do not agree on anything. So one of the ones recommended is the Rockwood Clinical Frailty Scale, CFS, and there are others in use as well. The local emergency ambulance service uses the Prisma 7 questionnaire. Sensitivity and specificity is quite good. Some of the public health and social services around the country use the Edmonton scale as well. But the one I've been using for a while has been the timed up and go test greater than 10 seconds from the late 90s. And more recently in the 2010s, I started using the gait speed, that is walking 4 meters in greater than 5 seconds. It's got a pretty good sensitivity of 99% and a specificity of 64%. But that also, the gait speed I use in prognostic indicators, if somebody asks me what the survival chances are, if they've got geri-oncology, the pre-rehabilitation, we can use quite a bit of things. But the biggest thing about identification with the clinical frailty scale is mainly communication. So once you've identified, you can communicate to each other. One of the biggest things is that if you can communicate, it needs to be very clear, which helps you out in a very simple way. So it doesn't matter where you've identified the frailty, emergency services, primary care, rapid response, community services, or even an A&E, it leads to whether they need acute care or they do not need acute care. The difficulty is with not needing acute care, you can go straight to the independence pathway, the monitoring pathway. You don't need to come into the progress element of the one in acute hospital. The identification and communication, it also gives you a very developing right pathways as well. What it does is it gives you the data, and it's very rich with, we've used the data for us. We used to have 4 or 5 years ago, a rapid response activity was different. What we found was a rapid response activity is greater now on a Friday afternoon. We have long length of stay, so we have a Thursday post long length of stay, we have increased activity, and then on Tuesdays as well. So it gives you also the conditions which the patients are coming out with or being identified by these different services. The other thing which we noticed as well is we can identify areas of PCN we can focus our energy on. But the thing which we need to do is get agreement on the frailty scale, which we know, which is being used, the CFS Rockwood one. And then how do we respond to them is more important. What do we look out for? And everybody's looking out for a gold standard frailty service, but you do know the staffing situation, the amount of medics, the amount of AHPs, the amount of nurses are not plenty. But looking at the data, we can actually look at what kind of gold standard we can do with the current availability of the staff, and then how things can progress from there. Next slide, please. The bit with progress is it's after identification is really important. So we know that 20 to 25% of the patients coming into A&E are frail, of the frail age group. Around, if you put that into context, 150,000 patients a year unit, you'll be looking at 15 to 20 maximum per day who are frail and who need to be who need a specialist input. But we also know something's wrong with that bit, which is 80% of them can get admitted. And when you look at the length of stay data, if you look at patients staying, average length of stay for 65 hours around about 5 to 7 days. Anybody staying more than 7 days, usually they are plus 65 years of age, 60% are 75 years of age and more. And then if you look at more than 14 days stay, you're looking at people above 75 years of age making 85% of the population staying in these beds. So the difference for you is in A&E is only for stabilization. It's for emergency care. If the patient does not need stabilization, then your identification and communication helps to take them to the right pathway. That means it's an acute frailty pathway. If they've got red flags, Rob, finally I found my spelling mistake. That's the red there. The red flags is my spelling mistake there for the day. So thank you. If you get a new score indicator that they need escalation of care to the ICU or ITU, that's good. But don't forget, at the identification itself, your CGA starts. What CGA you say, if you're looking at physical causes or physical examination, it's already done by the ambulance crew. Social and environmental aspects of the patient you've been reviewing, it's done by the ambulance crew. Functional aspects of the patients, the ADLs are usually done by the ambulance crew. The instrumental activities, the finances and others might not be done by them. They do element of risk as well. So that's also already been done. Again, the mobility and balance, they're experts. They have done that already. And the bit about psychological and mental health mood, they might not do it, but if the patient has got known depression, that's different, or anxiety. But if it's got dementia, it's identified. The element which they do partly is they will have identified the medication review. The element which they would have identified would have been if the patient taking the medications properly, or if the house has got 50 boxes of cocodamol or alendronic acid for the last 3 years kept there, so they can do that as well. A majority of the information for a CGA is available in the ambulance history. I mean, following frailty identification, we need to be very clear what the patient needs. If the curb score 65 for a community chest infection, if they got a stroke, if they got acute kidney injury, they do need to stay longer than 2 days, then they need to be moved or transferred right away to a specialist unit where they get specialist treatment. If they are not in any of those categories, then you start thinking about, okay, they don't need stabilization, what to do next? You will go into the criteria-led discharge. But the criteria-led discharge will come in with very clear implementation of what you call as your board rounds, your safer bundle, and your discharge planning. The discharge planning without an electronic discharge summary or with the TTAs or take-home medications not done and transport fix, the patient stays forever. The difficulty is it needs to happen in a coordinated way to identify patients to different pathways. But what this also gives you is which one I am a big proponent of is the marginal gains theory, which we use the IAD process. Let's identify, analyze, and develop. One of the best examples, I'm sure Jyoti is going to talk about it in the next, where South Warwickshire used data, identify, analyze, and develop the pathway. So it'll be a really good example when that being brought in. But it's again, partly due to marginal gains theory as well. I mean, the difficulty is that people don't understand a small 1% change every day can increase your productivity, your efficiency, and decrease any kind of problems by around about nearly 38 to 40%. So we're looking at very tiny gains and developing your with the staff and what you have over there. The bit which when you identify pathway 0 patients out, they are easy to find out if you ask them. The bit which we need to understand is if they don't go into pathway 0, there's certain things which we need to be very sure about. What are the risks for these patients? We talk about risks when the patient's admitted for elective care. We don't talk about risk when the patient is not admitted for elective care. Classic example is falls. A 65 plus person living in the community has a 35% risk of falls. The minute they hit the buildings, it doesn't matter, acute care or a community hospital or in residential and nursing homes, the risk goes up to 50%. They only have a 1% falls risk when they have a fall of hip fractures in the community. The minute they have a fall in an inpatient setting, the risk of falls of hip fracture goes up to nearly 50%. Clark as well, it was a study done in Scotland. He showed that he followed up patients who are 80 plus, got admitted to Scottish hospitals, and then 1 year later, he just looked at them and found what has happened to them. What he found was 48% of 80 plus were dead within a year. So these are pretty frail patients who and also again, as you know, the longer they wait in A&E, their risk of mortality increases over their duration of stay in the hospital. They also have other issues, which is increased risk of delirium, that increased risk of iatrogenic infections. COVID has been in the picture for the last 2 years, and we know that 25 to 30% of COVID infections in the frail elderly was iatrogenic in hospital as well. So we're exposing them to quite a few things, especially if they don't need to stay in hospital. The delirium itself increases the risk of death and increases the risk of nursing home and residential home placement. So if they don't need help, it's pathway zero. But what do you need to think about is what can keep them out of the hospital. So one of the things which I put up here is Callum talks about it as well, who's one of the improvement managers. A phone call from the ward discharging the patient decreased the readmission rate by 41%. That's a pretty good number. But when I started doing this a long time ago, I started asking the question, and most of them said the same thing. I don't have a clue. I'll talk about the clue bit later on in the few slides. So the bit we need to focus on from admission is to enable safer discharge. The ambulance crew have already started the journey for us. The majority of the CG elements are done by the ambulance crew. And then if you could explain the risks of an admission if the patient doesn't need admission, just like in elective care, that might help the patient focus their risk. The risk is taken by the patient. We're facilitating it by eliminating the risks and telling them that this is the right thing for them. And also, the next step would be that it's timely and the patient understands it. And then if necessary, you go into pathway 1. Next slide, please, Rob. You might think about path monitoring. So monitoring is mainly, it can be done anywhere in the specialty ward, it could be an acute frailty ward, could be pathway 1, virtual ward, rapid response, even a pathway to intermediate care beds. But don't forget the hospice. Hospice at home or CHC fast track of end of life. What we've known is that when we looked at the data or looked at the studies published, if you look at the last 1 year of life of patients who have died with palliative or non-palliative, they have had at least more than 6 admissions in the last 3 months of their life. That means that was never considered, a palliation or hospice at home was never considered. If you look at the GP workload as well related to deaths, on an average, a GP looks at 20 deaths per year, and then the proportion of death was quantified very clearly. So there's 1 or 2 deaths out of the 20 is usually unexpected, but 50% or 8 of them were patients who are frail, who had comorbidities and dementia. So you're looking at even palliation, patients are frail, so 50% of them frail. Other 5 or 25% was mainly related to cancer care, and then the other one is the organ failure. And the trajectory of death as well in the patients with cancer, you got a steep, they chug along nicely, and then there's a cliff, and the pun is not intended, but their care drops off the cliff. But with the patients with organ failure, you know that there's lots of dips, and then they have a sudden dip, and that's where they go into the palliation and death. But in frailty, you've known about them for a while, and they keep going in the last 3 months of their life, they seem to have quite a few dips and out, but nobody's identified them, and they don't seem to get the right care at the right time. So if you think about what to do next, you do need to ask yourself, these patients as well, they don't know what happens. They're scared. Their family members don't know what happens, especially if they know that the process of palliation has not been talked to them. So they go to the easiest access. The patient calls 999, or the family members call 999, or the care home calls 999. If there's a GPs who do not have proper pathways, then their only access will be 999 as well. Again, monitoring is mainly to decrease risk, but promoting recovery at home. The most number of beds is in the patient's home. They know what to do when they're at home. Somebody's taking care of them, of their immediate health care and social care needs, caused by a sudden dip in their health or some kind of long-term condition causing the dip, that helps them out to be in their own surroundings and them to recover faster as well. The bit which monitoring, if you want to do this, there needs to be an early identification pathway, and then they can be either part of the rapid response or they could be part of the virtual ward as well. Virtual ward has grown immensely during the last couple of years, especially led by the respiratory COVID response. So I think there's lots of things we can learn from there as well. The decreasing in admissions, readmissions is important, but it's just not provide monitoring to anybody you think you're scared of they might readmit. You need to ask yourself a few questions. The monitoring or any help of health and social care or pathway 1 or a rapid response need to be provided for patients who meet certain criteria. The ones which I ask myself is, can the ADL or activities of daily living or can be recovered easily at home? And are there sufficient or willing caregivers available to assist them in this transition? And then do they need help with meals? And if it's yes to any one of them, then you know that they are appropriate for a monitoring pathway in the community. It could be rapid response pathway 1 or virtual ward. It could be pathway 2 as well. But when you look at the data, when we know that readmissions is quite high, especially for a frail patient coming out from a frailty unit, it's around about 35% in the next 12 months, 50% if it comes to an acute medicine and a not frail unit. But when we monitor them, if they have monitoring questions as positive, then you know that once you monitor them, their readmission rate decreases from 35% to about 10 to 11%. So you're looking at the same people. Even when you look at the CGA medication review, when you look at the admission of frail patients, nearly 16.5 to 17% have got readmission risk in the next 12 months, mainly related to their medication review as well. Medication related incidents as well, them taking too many meds, taking too less meds, or anything like that. Next slide, please, Rob. For independence, I kind of, it's a simple mind, so I need to categorize it into simple categories. So I categorize them into the categories which makes it simple for me, which is patients needing episodic care, but they might not need follow-up or review, but you can still signpost them. The classic example is somebody not listening to the wife climbing up the ladder and breaking in a hip or breaking an elbow, trying to do DIY. He doesn't need much other than signposting. We know that strengthening and balance exercise is recommended as a quality standard by fracture hips or anybody with falls. The other bit is people forget pain control is a big issue. So signposting to your PCN pharmacist or the GP or the pharmacist for pain control is important. Again, if their mobility or activity is decreased, then they can also use the PCN, AHP professional or physiotherapists who are part of that service right now. The second aspect which I think about is if the patients have got repeated access to the GPs, to the community services, we see in our local data nearly 40% of our rapid response is spent on nearly 10 to 18% of the patients we have seen in the last 12 months. So we know that they're repeat users of the service, but it's not related to just them using it. They're coming to the right place for the right care at the right time. The thing which we need to do is, what does this patient need? So identifying what they need for follow-up. Classic is we were locally lucky enough that one of the PCNs in Wellenberg did good work on the social prescriber element. When we found out that the element which was most needed was 88% of the follow-up was mainly social prescription. It was nothing related to healthcare. Only 2% of them needed a GP or a frailty or a palliative care medic to be following them up. So there's lots of things which are happening which they can get access to. They're caseworkers. Some of them might have housing support. Most places have got, you can call up and they can put a rail in or call buttons in. They can, the transport which is a bit funny because there's lots of parishes who have done lots of work for social isolation, looking at social isolation and increasing the patients to be part of the community. We know from studies mainly that the Farmingham study, which has been running from World War II since the G.I. Jones came back from Europe to America, the only thing which is proven to increase longevity is being part of the community. And so we have lots of parishes which have put lots of effort to increase tea evenings, dance evenings, and communication evenings, cultural evenings, but they don't have any transport. So just getting voluntary transport for them might help. Again, most of the places we got locally, every parish has got Otago or Tai Chi classes. It's just restarted post-COVID. So even in patients with Parkinson's, we know that yoga, Tai Chi is helpful. Again, social isolation, which was very interesting for us, is sometimes they call health and social care services to chat to somebody. That was the most interesting thing we found. Then that's because they said there's easy access to them. But don't forget, since April, we have a 2 hours response for a rapid response. That means they know now that there will be somebody getting to them at 2 hours. But if they got a health and social care need, great. That is the perfect thing for them to do. But then again, when we asked them what will keep them at home, this was the I don't have a clue element, which was I was talking about previously. So I split it down into something simple as communication. One of the things which the National Discharge Policy says now is that every patient should have electronic discharge note with a contact access for the ward in case the patient has got any kind of queries about the care to be done going home in the next 7 days. So that is a clear communication issue which is identified and put in as a guidelines for us, even in the National Discharge Policy. The bit which we forget is there's loads of leaflets available for different conditions. Again, lots of charities are invested, lots of websites. Family members can be up to date with websites and technology. They can make their their family members look at videos. The charities and services have got video access as well. The bit which was interesting for me was learning from others was really important to them because these are born in the 1940s, 50s. They have been through something together and they know how, and they listen to each other. Well, I mean, wives don't listen to the husbands, which is still happening. I'm not that old yet, but that won't change. So what works for them will be what they can hear from others of what worked for the others as well. Understanding the condition, it's actually of no use if they don't know what to do next. Doesn't matter how much they understand, if they don't know what to do next, that is really important for them. So the bit which we know right now, there's escalation. GPs are amazing at putting plans for especially COPD exacerbation with relief medication, starting on steroids and antibiotics. We got self-monitoring as well. Patient and peer groups, a lot of them are self-monitoring now, and they can learn from each other. The interesting thing is if we tell them something which is okay and nothing's wrong, they might not listen to us. They will listen to somebody of their own peer. And I think self-monitoring and then being part of the peer group is really important as well. The bit about telehealth is please choose wisely because patients, when we've done rapid response for the last few years, we've been monitoring our patients since 2007. We know that when the patient deteriorates into a news which needs admission, they do it suddenly. They rarely do it from a news of 1, 2, 3, 4, 5, and they don't go up like that. The ones which get admitted usually are a sudden escalation of care. Otherwise, if the patient does not know why their observations go up and down, it might increase anxiety as well. The bit is, again, they can self-refer. That's really important for them. We do have our patients locally, mainly the bronchiectasis patients. We're running out of them because they survived and their patients numbers have decreased. Some of them have not gone to hospital for nearly 5 years. We forget about them sometimes. The process is we escalate the care. If the patient feels they're feeling unwell, they call the rapid response team. The GP has advised them to start the relief medications. We get the sputum done. We take the bloods. We check the bloods, discussed with the respiratory team, and if the culture comes back, they advise on the antibiotics. If they're getting more than 3 intravenous antibiotics a year, we suggest a central line, which respiratory team helps us out, and they get that done as well. So there's lots of things with the clue element, which is we can win with these patients for especially the repeat access and repeat admissions. I mean, we know that they're nearly utilizing 40% of our resources, so I don't know what else can be in other places as well. So we can look at the data for that one. The next slide, please. The bit about repeat admissions is a consensus issue. It depends on the conditions as well. Then how long do you think they need to be monitored to say they got repeat admissions? As a general rule of things, I use more than 2 admissions and 3 months is a repeat admission for me. That means if they've got complex comorbidities and then they've got polypharmacy issues, which is more than 10 medications, but I'm a geriatrician, so even 1 is polypharmacy for me. So that's not an issue. So they need to be looked at in a different way. There are lots of things which are helpful currently. So we know that the Frailty Index is available. It's depending on the different parameters they meet and different conditions up to 50. So they can be split into mild, moderate, and severe. We know that severe ones last up to 3 years, and the chances of death is more than 75% in the next 3 years. So there's lots of indications for that. I use the Charlson Comorbidity Index, which is quite useful. I've been using it for a while. It's a weighted index. It is the specialty condition-led index, up to 14 different comorbidities. It's a direct indication of the possibility or risk of death in the next 12 months. So we can put things into place. We published in the BMJ palliative care, and we found that 25% of our patients coming through rapid response were no more in the next 12 months, and 36% were no more in the next 48 months, or 24 months. So we have a consultant palliative care physician as part of our service. One of the things which we learned is asking the gold standard framework prognostic indicator question, the surprise questions. To be surprised if this patient were to die in the next few months, weeks, or days? And if the answer is yes, and then you correlate it to the frailty aspect. I mean, they're deteriorating, they're deconditioned, and they're declining as well. And then if you add in the special clinical indicators, then you know that frailty will be one part of that, which you need to be identifying patients to be part of palliative care as well. And then looking into how we can tuck them into the local frailty MDTs. Most of the country has been developing frailty MDTs. These patients should be part of the frailty MDTs, especially complex cases or frail or declining. The patients also might refuse treatment, or there might be no further treatment options. And that's where we do need to, in the frailty MDT, have a care review of what supporting needs they have. Again, palliation and advanced care planning. An example would be dementia, a patient who's non-communicative, been bedbound for more than 3 months, and with poor intake. If they have an escalation or ceiling of care to be in the care home or at home, it needs to be happening as soon as we can, rather than them coming to acute hospital and then going back and then actually making them go through a bit of delirium, a bit of confusion, agitation. It's not fair on those patients. Again, there's lots of PCM resources which are starting to be added up in local communities, which is a pharmacist, a prescribing pharmacist who can help in medication reviews, allied health professionals, physiotherapists, occupational therapists, and then paramedics doing the urgent visits if the patient needs help. So to summarize, and bearing with me, this is the model I use. Go ahead, Rob, for the next slide. You can press the next one, please. So the IPMI is in my brain, so I use that as a model for very simply identification. Again, I use the characteristics of frailty. The frailty scale helps to communicate clearly, and then also communicating to different pathways. Again, the next bit, please, Rob. And if you identify them, what are you going to do? Which pathways do they go to? Direct frailty pathways. If they don't need stabilization, do they really need to go to A&E? If they don't need any acute care, then the CG has already started. Well, how do you focus and get them into criteria-led discharge process? Identifying them to the different pathways. Don't forget about CLUE. The patient is asking for help. Communication, learning from peers, understanding the condition. But the most important is, doesn't matter what they do, how do they escalate to themselves? That can be done in the monitoring phase. Next one, Rob, please. Where it could be rapid response, virtual ward, but don't forget the element about hospice, which the patients have not been identified. They might have had lots of readmissions in the last 3 months, and then that can be a clue as well for these patients to be put into a frailty pathway in the independence section. Next, please. Independence is hopefully self-explanatory, but you categorizing them and simplifying them into needing some signposting, needing some repetition, and then needing a complex frailty review is really important. Thanks for giving me this opportunity to speak how I think and people actually listening to it. Hopefully it's helpful. Rob, I think I'm out of my slides. Hopefully, if not, I'm in time as well for you, so hopefully we got enough time for questions.
Brilliant. Thank you, Bharath. Thank you for sharing not only your mental model and adding to a growing community of knowledge around this, and particularly for sharing that with our collaborative colleagues. I guess there was a lot of work there where you've combined your experience with evidence with some practical common sense suggestions and solutions as well. So I guess there's probably something in that for everyone, where people can come in and pick and mix their different approaches. But I don't know about anybody else on this call. I think just listening to you for half an hour really does help my blood pressure in any way, shape or form. It's a really calming influence, and I suspect you have that same calming influence in your system too. So thank you for your time and kindness over this lunchtime, Bharath. I'm sure there's some questions brewing in the background. If I can just answer one of those from Laura already. Yes, we'll be sharing the slides, and we'll send the link through to the recording as well. Thanks, Erica, for stepping in on that one. In terms of pardon me, other questions from colleagues right across the piece, I'm looking at the chat box. Anything to add in, or additionally, put your hand up and have the chance to speak to either Bharath or Jyothi, who's also joined us now. And don't feel too concerned if you haven't, because I've got plenty of questions. Any hands up across the piece? Okay, thanks very much. Oh, here we are. Louise Hyde. Hi, Louise. Welcome.
Afternoon. I think one of my questions is one of the things we've struggled in Kettering when we've introduced Frailty. We now have Frailty, acute Frailty team, a Frailty STEC unit within our ED. Don't have a Frailty unit as such because the state doesn't support. Sometimes when we're asked for that data in regards to emission avoidance or reduced length of stay, it can be really, really difficult with the Frailty cohort of patients. One, because they're often outlied, because if they're admitted for not an acute episode, but more to facilitate discharge planning, etc., they are then moved towards that don't support their care in the best way they can. So sometimes it's that sourcing of data. It was just, you know, we're always open to any suggestions, but it's something we've struggled with over the winter months. We had a virtual ward approved throughout the trust, allowing us to track patients through the trust to try and ensure that Frailty was guidance and advice and specialty care was sourced throughout their journey to try and see if that had an impact on length of stay. And it's been quite difficult pulling all that data together to present the findings. So it's just, you know, whether or not anybody else has had similar experiences or any advice and guidance, because sometimes that's what the exec board wants, don't they? They want something very tangible evidence that will support, you know, reduced length of stay, bed days saved, etc. And it'd be really difficult in that cohort of patients.
And thanks for taking that, Jyothi. I was about to direct it toward you.
Now you've touched my sensitive chord there. So I'm not sure where the evidence is for not having a Frailty unit, Lewis.
It's not evidence, Jyothi. It's literally just a state, because where our Frailty unit was before is where our green ITU annex was in COVID. And that still remains an estate that's accessible for that purpose, because, you know, I don't know about ITUs nationally, but we don't have the confidence yet to completely release that estate. But we have had an emergency decisions unit, we've had a short stay unit, areas that have facilitated Frailty units before, but since COVID we haven't had the estate to be able to do that. We have got one in our proposed urgent care hub plans though.
Okay, and maybe in the next seminar, which I think we'll be talking about, I can give you absolutely robust evidence to suggest to trusts that if they actually invest in their Frailty as a priority, they will actually get emergency and elective flow. There is no doubt about the fact that most of the patients, as Bharath has just outlined, don't need to be conveyed. They can be managed in the community, yet they end up being conveyed. And not only do they get conveyed, they're admitted unnecessarily. And not only are they admitted unnecessarily, they stay for a long time, and they're not only harming themselves by doing that, but they're also contributing to this ambulance situation that we are in, where ambulances are not able to go to the patients who need them most. So I've got lots of evidence to show that, the bed occupancy is very high. The numbers are very few. That is the beauty of Frailty, is that the numbers are very few. Even if you stop 3 or 4 admissions a day or conveyances a day, you will make a remarkable difference in your bed base. And there is no doubt about that. Yeah. So, and frailty teams get criticized often that, look, we have invested so much in the big team, and yet you're only seeing a handful of patients. And I will strongly support that, that it is still to be supported, because it will still make a big impact on the bed base.
That's exactly one of the challenges we faced, is the numbers, and even changing mindset. So we have a medical aesthec, we have a frailty aesthec, and as a medical aesthec, they're building they've really increased their numbers, and you can very clearly evidence, admission avoidance, same day emergency care. The parameters in there seem to be a lot easier to pull out of data, because frailty don't see anywhere near those numbers, and their conversion to admission isn't matched against a medical aesthec per se. But honestly, trying to change people's mindset with a person, if you have a 65-year-old who attends and is on oral antibiotics with no new oxygen requirement, and they want to admit, you can go medical aesthec for if you want a medical review. If they're 95, why does it change so much when that individual may be independent, without a care package? I have a 92-year-old in the department this morning on all oral meds with no oxygen requirement, but a 48-hour anticipated length of stay.
Yeah, absolutely, Louise. I couldn't agree more. I've just put a graph there, and I don't know if you want, which trust are you in? Kettering. Okay, more than happy to, show you absolute evidence to show that frailty or concentrating on prioritizing frailty as a trust will actually give you the emergency and elective flow, which everyone is now bothered about. The beds, you will create those beds. It will take a month, but you need to persevere, and the numbers won't be very high, and they'll have to put up with that as well. But it will slowly show the impact on your beds. You need to use your frailty team very in a different way, and getting these frail older patients to the ED doesn't help, because these few numbers will block your ED very, very quickly. Because I can show you another slide where the time they spend in ED, whether they're admitted or even if they're not admitted, they still spend around 6 to 7 hours of time in ED. So they will block your ED very, very quickly, forcing the rest of your patients to go into your corridors. So definitely, frailty is something to be to be prioritized by every trust.
Brilliant. Jyoti, thanks ever so much. Louise, I hope you don't mind, but I think you're helping designing the next session there, and that's really really helpful. And Jyoti's got bags of not only the evidence, but the energy as well to help you not only identify the detail within that, but how do you present a good case?
So I think
back to your trust.
Hopefully I will have our frailty matron with me on the next webinar, who is my clinical expert and has really driven the frailty team within. So our frailty team is a multi-professional, and it's really grown in the last couple of years, and she's definitely the lead for that. So hopefully I'll have her with me at the next webinar.
Brilliant. Thank you, Louise. Thanks, Jyoti. Jyoti, your hand's up. Have you got something to add? Okay, brilliant. Let's go straight on to any other broader questions, please. Open to the floor for anybody. Okay, Chair's prerogative. Bharath, going back to your presentation, there's a lot of experience there. I guess there's no shortcut for experience. But what would your advice be to developing frailty teams like Louise's as they step out on their first steps? If you were going to pick the key elements of your medical mindset, what would they be?
I think volume is not an issue in frailty. I think quality is the biggest issue. If you got a multidisciplinary team, I mean, as I told you, the numbers are small, 15 to 20 per day. Out of them, I'm sure 8 will need admission. The other nearly 12 will need discharge out of the acute hospital. If you can concentrate your efforts on those, your CGA has already started. I mean, you don't need to start the new CGA. I mean, ambulance sheet, if I look at the ambulance sheet, that's my CGA indirectly. And the rest of it can happen at home. So I think focusing all the energy on the ones which can get out the same day, and then again, focusing the team, actually not letting go of those patients for the next 48 hours is really important. Anything more than 48 hours, the patient gets sucked into the sausage machine. That means you start getting into bed shifts, you can start getting into iatrogenic issues, but that also helps you in capturing the data as well. So for me, a concentrated effort and a short short period of time. Again, using the IID model, identify, analyze, and develop, and you don't need a big, and then the margin. Time you get SPC chart, people were not. That's where you got a multidisciplinary team and Frailty. Your efforts and what's the best for the patient is discharging them to a pathway 0 ASAP. Then kind of cocooning them not to come back in and to preventing the readmissions. Like even that team can make a phone call themselves rather than another team. They can identify anything and then they can build a relationship with the PC and Frailty teams. Most of them have got really good caseworkers now, most places. Talking locally, we're in the starting element of that, but so just building and communicating is really important as well. I'm sorry I covered too much, but as horses for courses, Rob, which is quality more than quantity. The completion of a CGA is important, but not the only thing. I think focusing, getting the patient out, then somebody helps. If the medication review and the prognostic indicators are sorted out, the rest of it can be done out in the community.
Brilliant. Thank you again, Bharath, and thank you, Jyoti, for your contributions as well. And thank you to everyone else on the call for adding their comments. Just a couple of things in terms of housekeeping. Now, in terms of the resources, you find the resources with regards to everything hospital-only discharge and more on ESIS NHS Futures or Futures NHS pages. Please access those. You'll find those on the web. Just moving swiftly forward. These are the next learning events in our calendar. You'll notice that Wendy Rees is the key contact there. We'll be sharing these slides out, but Wendy's an absolute font of knowledge on all of this, and she's helping coordinate our response in terms of the hospital-only discharge work. And last but by no means least, we can only build this based on your comments, and we want to make it reflective of your need, all of these sessions. It's great that we think we might have an idea, but it's better that your ideas are the ones that we follow through on. So I'd like to thank everybody for their contributions. Please feed back to us. That way we can help design it for the betterment of us all. With that in mind, we've got two minutes to spare. Time for a cup of tea, I would suggest. Can I thank everyone for attending today? Hope you have a lovely rest of the week and see you all again soon. All the best. Bye.
Thank you.